Thank you for this opportunity. My name is James Kangethe, and I'm from Kenya. I'm going to speak to you about high-risk human papillomavirus infections and cervical cytology results among women living with HIV in Kenya. At this point, I have no conflict of interest to declare. You find that cervical cancer accounts for over 300,000 deaths globally, and 90% of these comes from low and middle-income countries. Unfortunately, Kenya, my country, is not an exemption. We have an incidence rate of 15 cases per 100,000, 100,000 women. So cervical cancer is caused by the high-risk HPV, and we know that women who are already HIV infected are worst affected because of their unstable immune system. There have been reduced AIDS-defining cancers such as Kaposi sarcoma upon the introduction of ART, but we continue to see that there is a sustained increase of cervical cancer incidence. At this point, we are calling for elimination of cervical cancer. So many other interventions have been introduced, including vaccination, molecular testing, where WHO is recommending for screen and treat for HIV-infected women. And at this point, we sought to determine where we are. So we sought to determine the prevalence of the burden of the high-risk HPV infections among these mothers who are, or women who are already in care. And we went ahead and did cytological assessment for the same, or for those who had at least high-risk HPV infections. This was a snapshot study where we enrolled 647 women who are already in the clinic. And cervical cytological smears were corrected upon consenting, and at least this was run by a point of care pathogene expert. From there, we did individual genotyping to establish if someone had all the 14 or some of the high-risk HPV genotype. For the women who had high-risk HPV genotype, we went ahead and assessed their cytological status using the pap smear method. So as you can see, we are able to establish that our cohort had a mean age of 43 years. Majority of them had been on ART for at least 12 months, and the suppression rate was good at 79%. So when it came to the types of high-risk HPV or the burden, we found that out of the 647, 224, which is 34%, had high-risk HPV infections, which is way higher. And something interesting is that at this point, type 52, was more prevalent as compared to others. It has been a culture that we prioritize on 16, 18, and 45, but we can see from this data that we need to shift our attention to other high-risk HPVs. Another thing to note is that among those high-risk HPVs identified, 29.4% of them were vaccine preventable. That is from the nanovarient vaccine. Going ahead, we did the assessment for those who had the high-risk HPV infections, and we can see that at least 56% of those who had the high-risk HPV, they had some abnormalities, that is typical squamous cells of undetermined significance. We went ahead and we could see that 13% had full-blown cancer, or they had invasive cervical cancer. And for those who had the low-grade ASCAs, you could see that the genotype, the most dominant genotype was 56. Again, lining away from the HPV 18, 16, and 45, like we have been seeing in the previous trends. This was similar and replicated in those who had invasive cervical cancer, and this still calls for full attention to the 14 high-risk HPV genotypes. Age above 35 was associated with having an abnormal cytology if someone was infected, and having multiple high-risk HPV was also a factor to having an abnormal cytology. So what we are deriving from this is that we need to look onto the ways of optimizing the HPV vaccine that is present, ways of embracing what WHO is advocating, that is isolating the genotypes themselves, and if possible, use the point of care methods so as to ensure that we prevent these women who are already affected with HIV. At this point, I wish to acknowledge the study participants, the study team, and all the collaborators. Not forgetting you guys for listening. Thank you so much.